So electrical stim for muscle contraction. Okay. I added a couple of videos to what was there to help you a little bit understand, especially the slow twitch, fast twitch muscles. I think the guy in that video makes it so really easy to understand. And then the other guy also explains not so much the fast twitch or the slow twitch, but electrical stim for muscle is EMS, right? Electrical muscle stimulation. And within EMS is NMES, Russian, and FES, because they all stimulate the muscle to contract. So NMES is not for pain, it's for muscle contractions, right? And I know a couple of you guys tried that, and you started feeling a contraction right away. Not because it was for pain, but it's for contractions, right? So those are all considered electrical stim. So muscle contractions in innervated muscle, you have to have muscle contractions in de-innervated muscle. And again, parameters of electrical stim of contraction of innervated muscle. So you have to have innervated muscle to be able to have that contraction, right? And to improve on it. And then we're going to see if you do it on de-innervated muscle, does it help? What does it do, right? So AP propagation along motor nerves, that AP action potential, right, has to happen in order for you to get that movement, crosses neuromuscular junction, and then the muscle contracts. Now here, and again, it goes with that. So here's the muscle fiber type: slow twitch, type 1, fast twitch, type 2, contraction force, and this is why I put that video in there. That guy does really, really good explanation on the difference of why, right? For the slow twitch, the contraction is low, the speed of the contraction is slow, you are fatigue resistant, atrophy resistant, and then the recruitment is asynchronous. Electrical stimulation is going to hit your fast twitch muscles. It's usually a high contraction force. The speed is fast. You're going to fatigue quickly. You're going to atrophy quickly. And it's the recruitment is synchronous. So what do you see just from this table?
E-stim is a lot more intense.
Right? It's more intense. What else? Right? So an electrically stimulated contraction is only going to affect the fast twitch type 2. Right? But what else do we see there?
Recruits all muscle fibers.
At one time. Okay?
Makes it higher.
Yeah, it makes the fatigue quicker, and it atrophies quicker too. Okay? So keep that in mind, right? When you're thinking about, like Cam was saying, they use this on athletes with the thinking that it was going to make them stronger. Yes.
So it's probably better for short term rather than long term.
Right.
You don't want to be doing this.
Right. But they did in the thought that it was just going to bulk them up.
But they probably saw muscle
But yeah,
atrophy and only everybody was
or if you increase the stimulus so much where they can't recover from it.
Right. Yes.
Well, the atrophy is not. Atrophy from doing the actual.
I think it's more that it just doesn't
doesn't
stay. Yeah, doesn't maintain. So how does ES strengthen muscle? The overload principle increases pulse duration amplitude, electrode size, a higher load, higher force, contraction, greater strengthening. That's the principle of it, right? Contractions specifically strengthen fibers that contract. Electrical stim is more effective on type 2 muscle fibers than type 1.
It says it's more effective, but it's not as safe, right? So,
Whereas I don't know if it's safe, but then you're not gaining what you wanted to gain.
So, I mean, would the stimulus from the contraction just be like, it's firing all the muscles at once, right? Like, that's the whole point of it, but, like, that makes sense why you wouldn't gain a bunch of muscle. It's more like motor firing than anything, right? So you're trying to teach the muscle to fire, but you're not actually giving it that overload.
Right, because you're and I think I'm gonna play that one video for you guys to understand, because your type 1 are the ones that are going to be able to, like, for example, your type 1 muscle fibers in your legs have to sustain you all day long, right? Those type 1s are the ones that need the strengthenings to be able to allow you to stand all day. Because if you're just relying on the type 2, you're gonna tire out real quick, right? So understand that electrical muscle contraction elicited by electrical stimulation only hits the type 2s. It doesn't affect the type 1s, okay? So disuse atrophy is primarily type 2 fibers. Again, one thing is to stimulate the muscle artificially, and it's only stimulated while the stimulus is there, right? Versus you're doing it on your own, which is going to be better, okay? So why do we use this? Again, strengthening of ACL reconstruction and total knee arthroplasty. Strengthening, not that you're gonna put it on and that alone is gonna strengthen, because we can see that it's probably not going to. But why do you think we use it for ACL reconstruction and total knee replacements? Yeah, because they lose that. Anybody here has had ACL repair? Yeah, from what I've heard, people that have an ACL tear and repair, there's that point right after surgery where you're like, you can't fire that to do this. You cannot fire that clot. So it's like you're giving them that stimulation to say, okay, body, this is what you need to do. This is what you need to do. Yeah, so it's to create that route again, right? Re-education. So muscular re-education. Once they are able to do it on their own, then you're not going to use the electrical stim. Okay? Osteoarthritis, rheumatoid arthritis, patellofemoral syndrome. Again, it's just for re-education. Okay? So that you know which muscles to use. Stimulate neurological disorders, spinal cord injury, strokes, MS, TBI, CP. Again, it's re-education, but you have to have an innervated muscle, right? If you do the stimulation in a de-innervated muscle, you're only going to get the mobility when you're firing it through electrical stim. It's not going to magically innervate the muscle, right? So you're getting the movement as the stimulation is there, but when you take it away, the muscle's not going to just miraculously move. You have to have intervention in the muscle to be able to continue to improve with that. Okay? So this is where functional electrical stim comes, right? We mainly use it, they use it in the shoulder, they use it in the ankle to get that dorsiflexion for walking, right? So it comes on as you're taking that step to clear your toes. Once you take that off, the patient is innervated, they still have movement, they can improve on it. If that is de-innervated, they're just going to have it while the machine is on, okay? So in your spinal cord injury, it depends if they're a complete spinal cord injury, which means they're complete, everything under that level is gone. There's no intervention in those muscles. And incomplete means there's some here and there, you can't pinpoint where, so you can try this, okay? Again, a TBI, a head injury, isn't sometimes not just a head injury. They have other, how do most, and we're gonna go over this, not to give a lot away, but again, a head injury, how do you get a head injury? Right, so are you just gonna have a head injury?
No.
Probably not. You're gonna have other stuff happening, right? So, again, it's all re-education, right? So again, here, it's just, counteract disused muscle atrophy, improve circulation, contract muscle to assist with locomotion, contract muscle to assist with hand grip, respiration condition. So it's to help the muscle that's still there to get better, right? Because they're not moving, they can't do aerobic stuff, they can't, get on a treadmill. So this is just helping the muscles that they already have that they're not really using. They have to have sufficient force to carry out the activity. So if you're gonna do it for, like they said, to improve their hand grip, they have to have some force, right, to be able to tolerate that. Again, it depends who the user is. It shouldn't be painful. It can be controlled and repeated, so they have to have that cognition to be able to understand what's happening. For strokes, again, to improve gait, usually dorsiflexion, reduce agonistic, antagonistic co-contractions, increase probability of returning home. But they have to have movement. Again, this only works if you have movement, right? If you don't have that intervention, it works while you're doing it. So if that helps a spinal cord injury be able to breathe better, then that's fine, right? You're doing that. But it's not gonna make the muscle work again or improve it for that matter.
How many is it the same machine, like Russian?
Well, no, they're different machines. And on the video that I posted, his little machine does NMES, right? Which he uses as Russian, right? So they're all clumped in the same, electrical and muscular stimulation, but sometimes there's different machines, okay?
So like for stroke and stuff,
That would be the FES, a functional electrical stim, yeah. You can use it for all of them.
For the denervated, it's gonna be a direct current,
Right.
which is different than an FES. So the only thing that will make a denervated muscle contract is direct.
so we should know generally what it does for the muscles, we don't have to know which machine is.
Yeah, because our tower has Russian, right, and NMES, right, it's just the way you said it, whatever you
It's
have, yeah, available, right? The FES is different because it's not direct current like Ms. Hardy says. To get a deinnervated muscle to contract, you need direct current. That's what Russian is, direct current. And it's not comfortable, right?
But we should just know generally, right, for each, I'm gonna use this for stroke.
No, we're not, we are having you set up a Russian, right, which would be similar to, if you wanna do an MES, but other than that, for the FES, we're not having you do a skill check or anything on that. We don't have an FES machine. I don't know if those do.
We looked at them.
Yeah, and it's special, you're probably only gonna do it if you work in a rehab center that does a lot of strokes and a lot of like spinal cord injury, like a neurological, then they would have that. Or in an outpatient setting. If you're in an inpatient setting, we never get to that point. So you can use it to reduce agonistic spasticity, Contraction increases agonist strength and control. Again, for strokes, right? You're going to try to fight that spasticity that they have. Sports medicine, addition of NMES for strength training can enhance strength gains, may or may not enhance functional performance. It's not a substitute for sport-specific training. Again, remember, this is a modality that you add on. You look at your research, is it making a difference? Okay. Dysphagia, other conditions, urinary incontinence. So dysphagia is for that swallowing, they're having those swallow muscles. They have a special little machine for that only the speech therapists use. They're trained on it. They do put those things to help with the swallowing mechanism. And then for those of you interested in pelvic floor, you do use this type for re-education on the pelvic floor muscles. Okay. Promote circulation, reduces risk of DVT formation. So just muscle movement, muscle contraction. Okay, so requires pulse duration. This is for de-innervated muscle equal to electrical muscle stimulation. Uses continuous direct current. Improvements do not persist after stimulation stopped. So you use it just for that moment, right? To get that maybe just circulation going and so forth, but it doesn't do anything for those de-innervated muscles, okay? Electrode placement, one electrode over motor point, the other over stimulated muscle, aligned parallel to muscle fiber direction. Insert electrodes at least 2 inches apart. So I'm going to use one channel, 2 electrodes, okay? One over the motor point, and the other one over stimulated muscle. So keep the joint in mid-range, isometric or isotonic contraction. So the second video that we have there, he's got his leg hanging, which really should not be hanging. You should have it kind of flexed a little bit, and that's how we're going to do it. And then they're going to go from here to here versus all the way down, okay? All right, so electric configuration here. So you're going to, over the proximal and distal ends of the quadriceps muscle for maximum efficiency. So that's where you're going to put it. We're not all the same, so you might have to play around with it and readjust those electrodes on people, okay? Again, they talk about the amplitude and the pulse duration. I think our machine is preset, so you don't have to, worry about that. So, and again, the video explains this to you too. 20 to 30 pulse per minute, pulse per second for smaller muscles. 35 to 50 pulse per second for larger muscles. And then 50 to 80 pulse per second may increase muscle strength, but also increase fatigue. And as the video is going to say, for the Russian, when we do this for the quadriceps strengthening, you're going to do 5 to 10 reps done. Because that alone is going to fatigue, right? You're going to fatigue the muscle really, really fast. Okay, yes?
So do you adjust the frequency then to the size of the muscle too?
Yeah, and like I said, I think our machine, we'll have to see, I'm not really sure, but I think it probably has just some set parameters for that. But yeah, smaller muscles, right? You're going to do the wrist versus the quads, the shoulder, right? Ramp up times. Here we do ramp up, so it kind of takes a little while. And when you guys set up yourselves, you're going to feel it coming on. Like you feel it hitting on, and you feel it go. And you can set it, it's basically Karen used to say, are you the kind that you just rip off the Band-Aid, or do you want it slowly? So do you just want to get there, or do you want it to go slow? The video doesn't suggest that you go 0 to 90, right, all at one time, but you can try and see how it feels. So yeah, you can feel it, and then it just goes whoop off. All right, so contraindications. Again, pacemaker, unstable arrhythmias, over cardiac sinuses, over venous or any clots, pregnancy over the trunk. Why you would put this on that, I don't understand. Cardiac disease, impaired sensation, ornamentation, because it can't tell you how they're feeling. Malignancy, skin irritation, open wounds. Same ones, right? We're just over and over. You wonder why people, these are there, somebody must have tried.
So for this one, like, I guess Russian in particular, what are you telling people to expect? Like, is it gonna be painful? Like, what? It's gonna be different than
Well, you know, don't say it's really gonna hurt.
Yeah.
You have to have them buy into it, because you want them to get that re-education, right? Say, it's gonna be pretty uncomfortable, but we really need to do this to get your muscle to wake up.
Is there any like sensations that we're like that we're not looking for? You know?
I think you're just looking for whether the patient can tolerate that direct current enough to get a contraction. And there's always somebody in a cohort where it's so painful. I mean, we had one actually when she was crying because it hurt so bad, and she never got a contraction. So we couldn't get it high enough for her to get a contraction because it was so painful to her, right? So again, I want you to all try, and then you will find out who can tolerate it or not. If you cannot, after you've tried it, then we good.
I
You
bet
don't have to do it
Just
again,
after
but
this-
you gotta do it at least
I bet
once.
Jacob wanted to feel.
so like heavily meditated.
I don't know, we were doing IMC the other day, and I was getting contraction like immediately before I could even feel.
The sensation, yeah. There's always somebody in the group.
Emma was like that too.
Well, I was a little bit.
I think he is gonna tolerate it well. We did like.
I did a lot, but you got contractions before you.
All the way up, and she's like,
Happy.
I'm sorry, guys.
she's like content. She didn't feel it for a long time.
I
She
wanna
was-
I think
Alright, so adverse effects, burns, skin irritation, and pain. Right? If it's too painful, you just, that's, okay? Again, the PT's gonna do all this, evaluate, determine appropriateness and safety, select the device. You need to explain it, right? What is the reason we're doing this treatment? Somebody come up with an explanation right now. See how well you do.
We're using it to reteach your muscle how to fire.
How to
Contract.
Because if you are, think about, if you're doing this treatment, they're having trouble with that. They're not being able to do that motion, right? And so they're usually young athletes who are like fearful that they're never gonna be able to move their leg. So you say, you know, I know you're having trouble firing that muscle. This is gonna help that, but it's gonna be uncomfortable, but, you know, this is gonna reteach your muscle how to fire. So let's try it, right? They'll do anything to get that leg moving, right? You're not doing this on a 80-year-old little old lady with the knee replacement, like, why? Right? You can find other modalities.
Looks like Russian different. Well, I know because NMES is not direct, right? Russian is like why would we? Like my understanding is direct current is for degenerated muscles, but why would we do Russian?
So say you have a complete spinal cord injury and we want them to stand up in the parallel bars,
Yeah.
they have some, DC current braces that will help them come up to standing, right? So they can weight bear and they can at least get that movement, sometimes even take steps. Now, is it functional? Probably not, but it's getting them moving, it's getting them weight bearing, it's
Your
So-
breathing, all that.
upright position, all of that stuff. So, and then once you turn that DC current off and they're down, it's done. Unlike muscle rehab, where you're, that's.
Direct current.
And so if it was just the, like, recovering from ACL surgery, then you would have to do NMS, right?
For FES.
But I mean, again, you could do the Russian current, just to give them that, you're still re-educating with the Russian current, knowing that you're not gonna use that all the time. Once they get that movement, then they don't need to be stimulated anymore. It's just to help them get that movement again, because they say they can't, like, they don't know how to recruit that anymore. You treated a lot of ACLs. Did you ever use the Russian on them? So it's for a short period of time, right? It's not for long periods of time. Again, for your documentation, the area treated, patient position, your stimulation parameters, electrode placement, treatment duration, responsive intervention, should be included in your documentation. Okay? And I think that's it. So the two videos that I want you to really watch are there, so, well, all of them, right? But the one where it explains to you the fast twitch and slow twitch muscles, so you know the difference, right? And the other one is just another explanation of EMS. He does a really good job with the chart to explain it to you. I thought that would help you guys understand that. Okay. Anything you want to add on the question?
Is that just for the ACL?
Right.
Anterior to peroneals, disc herniation, that's not the job.
So I guess maybe I'm still a little confused and like going off of Lynn's question. Why would you, like with the ACL and still innervated, so why would you want to use a direct current like the Russian compared to doing like the FES or NMES to still get that contraction? Because you just need a stronger current to get it to go, or?
The FES, you do with functional activities. So,
So like
with
a
an
walking.
ACL, why would you have that weakness?
It's not prepared probably.
That inflammation, especially with knee issues, that terminal knee extension, any sort of inflammation or water in the area, that muscle will inhibit it. And they're really protective around it, they don't wanna weight bear on it because of their injury, so just getting them to recruit it. It's usually supine or long sitting, and you're just having them contract that. The FES is a functional thing, you're doing it with reaching, you're doing it with stepping up or walking.
So for the ACLs, like there's so much fluid or inflammation that it just can't contract on its own.
So those two videos, please watch, just to understand, remember we're talking about how the electrical stim only, or, is not going to, or the Russian hits that fast twitch muscle or fibers, right? Once it's off, it's off. He's ready. He's been antsy about it.
Are we putting bets on who's gonna cry first?
Already
Well,
ready.
we were talking about that, they were talking about, who did they say was going to not feel it? Jacob and Leah, and then who did you say was gonna cry?
Cam.
I wanna.
Cam, even before you turn it on, it's gonna